we can go for the next, the last presentation for Professor Zileli.
Hi, everybody. I'm sharing my screen. Is it okay?
Yes, okay.
Yeah. The last talk will be dealing with the fusion options in lumbar spinal stenosis. We know that many friends are doing additional fusion surgery in many spine stenosis patients, and is it a correct action or not? We must answer this now. If you look at the motion segment theory, there are three motion elements in the spine, in the lumbar spine. Two of them are facet joints, and one of them is the disc. It is not a real joint, but it is there. And then that three parts make the motion segment. And we know from Kirkaldy and Willis there are three phases of the degeneration. And first it is the dysfunctional phase, then unstable phase, and the body itself try to stabilize the level of unstable segments, motion segment. And that results with a stenosis, a real static stenosis. Somebody even tell something about the dynamic stenosis. This is the progression of degeneration. And if we consider a stabilization surgery in a case with rest stabilization phase, it's not correct. In the dysfunctional phase, it is also not correct. Probably in some cases, with a limited number of indications, during the unstable phase, we can consider fusion surgery. If you look at the normal mobile segment and degenerated mobile segment, there are significant differences. The disc height decreased, ligaments laxed, and facet joints are overloaded. And so-called ligament hypertrophy is not a real hypertrophy, actually. It is a buckling of the ligaments, as you know. So at the end of the dysfunctional phase, there is a soft stenosis coming mostly from the disc itself, then a subluxation and a dynamic stenosis during unstable phase, and after a hypertrophy of fascias and ligamentum flavum, the heart stenosis phase happens at the rest stabilization phase. And the surgical indications are mostly relative. These are neurogenic claudication only, more than 95% of the patients. Absolute indications may be cauda equina syndrome or major motor deficits, which are quite uncommon in lumbar spinal stenosis. This is a typical case of cauda equina syndrome I have seen in a 32-year-old male, very young male. He came to me with a perianal sensory loss, and CT was showing typical congenital canal narrowing with very short pedicles, and not only the AP diameter, but also the lateral diameter of the spinal canal was narrow. What are the surgical techniques? The other friends have nicely presented how to make the compassion. And if it is a fusion, currently we are applying pedicle screw fixations very often. And for fusion, we apply either interbody fusion or non-instrumented or with instrumented posterolateral fusion. When the fusion is necessary, the fusion is necessary if you create a iatrogenic instability. It is possible after extensive facet resections and or 3 levels total laminectomies. It may be possible. What about degenerative listhesis and back pain, if there is such a condition? Degenerative scoliosis with back pain or flat back syndrome and kyphosis, these cases may go to fusion. And so we have one term that the complex lumbar spinal stenosis may happen if there is degenerative listhesis, scoliosis, kyphosis, or previous lumbar spine surgery, postoperative adjacent segment stenosis, or radiological instability. This is a typical case of flat back syndrome. This lady, 60 years old, was walking like this in the anteflexion posture, and standing lateral X-rays was typical of a lumbar kyphosis. Suggestion was an L4-5 osteotomy and TLIF surgery with instrumented fusion. Even in degenerative listhesis plus stenosis, decompression alone may be used. But if you are preferring a fusion surgery, there are different techniques to make the fusion. When is a decompression alone surgery is possible? In case there is osteophytes already and no movement in dynamic films, so-called stable segment with osteophytes, or stable degenerative listhesis, we can apply decompression alone. Decompression plus instrumented fusion may be indicated in cases with more than 3 mm anterior listhesis, mobility in dynamic films, preserved disc height more than 2 mm, sagittalization of the facet joints, and if there is no osteophytes, if there is significant osteoporosis. And the techniques, as I mentioned before, it may be interbody fusion techniques. There are different ways, as you know, posterolateral fusion techniques. Another option is the dynamic fixation. Some surgeons prefer this to avoid the problems of fusion because the fusion surgery may have more morbid, and it may cause some adjacent segment degeneration. Although even after dynamic fixation, adjacent segment disease may happen, this is less likely. What about the evidence in the literature for fusion surgery? There are different studies, as you know. One of the studies is that from 2015, a meta-analysis saying that decompression plus fusion is not more effective than decompression alone. They have searched for many other studies. This is one of the most cited publications from New England Journal of Medicine from Swiss group, Sweden. They have found that the decompression plus fusion surgery did not result in better clinical outcomes at 2 years and 5 years than the decompression surgery alone. This is again a large study from 2018 looking at the degenerative listhesis case at L4-5 level, and they say in the conclusion, instrumentation for low-grade degenerative listhesis did not result in superior results to decompression alone at 1 and 5 years postoperatively. This is level 2 studies. Because of that, we also had a fusion or not paper after our consensus meeting. And there were mainly 3 nice studies, 3 RCTs, and these are spine committee recommendations. In patients with stenosis and stable spondylolisthesis, fusion is not mandatory and decompression alone is suggested. However, unstable spondylosis with symptoms may require fusion. These are recommendations. You can find them in our open access journal papers, and also in the website of WFNS Spine Committee. Since the factors for decision making, whether we must make a fusion or not, is so complex, there are some surgeons who have tried to make a staging system, and according to the scoring system, if there is more than 5.5, those cases will need a fusion surgery. One of the most important things in that scoring system is that mechanical back pain. It is 2 points. We must almost never consider a fusion surgery in a lumbar spine stenosis patients without any back pain. In conclusion, non-surgical treatment for lumbar spine stenosis may still be a good option for many patients. Decompression is the basis of surgical treatment of lumbar spine stenosis. Indication of surgery are mostly relative, only claudication, and to increase the quality of life. Unilateral approach, bilateral decompression is most popular surgery currently, but its value against iatrogenic instability is not validated yet. MIS techniques may have some advantages. In degenerative listhesis, decompression without fusion is still possible. Decision-making in complex spinal stenosis patients is more difficult, and fusion indications may be like those: additional back pain, overt instability, preserved disc height, and facet degeneration. But not only one of them must present, that 2 or 3 of them must present altogether. Better to perform short fusions, and fusion surgery has more complications. It may be up to 25%, and our decision should be affected more with clinical symptoms than radiology. This is what we are considering or suggesting for neurogenic claudication and lumbar spine stenosis patient. If there is no back pain, try to make decompression alone. If there is back pain and there is no instability in the radiological investigations, try facet injection, sacroiliac joint injection, brace and exercises. If there is no benefit, you can think about consider decompression and fusion. If there is a good benefit, you can consider decompression alone. And to avoid iatrogenic instability, try to use MIS techniques. I thank you for your attention, and then I want to invite residents in our area to basic spine course at the end of this month, and a live course in Uzbekistan at the end of May, May 31 to June 2. Thank you.
Thank you, Professor Zileli. We are at the end of our presentation. Thank you to all the speakers. You can take some comment or question before.
There are some questions we can answer. We can have still time.
There's a question from Harshad Parekh. It's on the chat. Aderehime, you want to read that, or maybe Yahya?
I can't see your question.
No. And I want to ask Salman Sharif, Professor Salman Sharif, do you
Yes.
have any comment for fusion indication for lumbar spinal stenosis? Because you have both Professor Zileli and you have good, nice paper, and Professor Zileli show us about some recommendations. And can you any comment?
Well, I think I totally agree with what Mehmet said. I think we in old days used to fuse everybody. I think that was incorrect. We know that there are more complications and patients' outcome is worse if we do that. So in selected patients, we fuse. So even if you the kind of patient that Mirza showed, I would still use a diamond drill and I would save the rest of the joints, and I would if they're old age, they're already fused. And in majority of the cases, you don't need to put in screws and stuff. And so I try to avoid, as people go older, that I use less hardware. As people are young, maybe I would if the mobility is there and stability is there. So generally speaking, yeah, I think over time we have realized that putting in hardware is not the solution. Decompression is the best option, obviously, but in certain cases there are specific indications, which I think Mirza, yourself, I think Nikolay and Mehmet have discussed here. So I totally agree with what Mehmet said, and the guidelines are very, very clear cut. There is no ambiguity about it.
And as a brief, you and Professor Lily showed us, Mirza again, Nicola Pierre again showed us, our aim is decompression. Fusion is less used techniques. Maybe MIS is over these techniques. We can prefer MIS, maybe.
Yeah, I think if you're good at MIS, you should. But in selected patients, as Mirza showed, if the decompression is required over a long period, and it's a massive problem. The decompression is very severe. Yeah, I think open technique may be used and microscopic technique may be used there. So in selected cases, you can choose. There's a question from Dr. Harshad Parekh, and he's asking.
Has his hand? You can, Dr. Mazagri.
Hi, good morning. Thanks for inviting us, and thanks for your effort all. One of the things, I agree with everybody, as we get older, we are more conservative, maybe because the number of complications we see over the years. One of the things we mention, but we don't stress on it, the physiotherapy. We need to put more detail when we say physiotherapy. What this include, for how long, and what is the aim of the physiotherapy? Are reconditioning the abdominal and back musculature? Is it electrical? Is it massage? Is it this and that? What is, in your opinion, we need to concentrate? What is the goal of our physiotherapy? Thank you.
Can I answer that? Aderehime, can I answer that, please?
Yes, please.
Okay, so we recently did again a consensus on back pain and the role of medicines, physiotherapy, acupuncture, physiotherapy schools, etc. And actually, the evidence is not out there. There is no clear-cut evidence. All the evidence we have is case series, individual experience, single center studies, and saying that, oh, we did a great job. I sent patients for physiotherapy and it worked very well. So unfortunately, we know that physiotherapy works, but unfortunately, we don't have any kind of a scientific study to clearly show that physiotherapy works better than other things. But we know that it works. So, but it's our fault that we haven't done a good study. There are studies out there, but they are very small. Have got serious limitations in those studies. So the data is not out there for us to say that, yeah, physiotherapy works very well. We have said in our recommendations that physiotherapy is a valid option, and it does help in majority of the cases. But, because the data is not there, we were not able to specifically say it. So, but these papers are out there. It is the paper that we recently published is in World Neurosurgery X, and it's also available on the WFNS Spine Committee website, and it's very easy to access it and see the data that we have. Unfortunately, at the moment, there is no good study to say that, yes, physiotherapy does work better than other ways of improving things. I think better thing that's been shown is change of lifestyle, exercise themselves, posture, working on obesity, other factors, smoking. So if you look at all those other factors, then they work very well. Education of the patient and how you talk to them, how you counsel them is more important than doing one thing on its own. So that's what we proved from our data on consensus on back pain with physiotherapy and with other things as well.
Thank you. But I want to say, in the same idea, there is some patients who have increased pain when they go to the physiotherapy, and they no longer want to return to see the physiotherapist. What do you think about this issue?
Mehmet, you want to take that, please?
Sorry, what was the question?
Physiotherapy increases pain when you send patients for physio. The pain increases in some patients. What is your take on that?
It may be possible if the physiotherapy is applying very forceful exercises, but in case of passive applications, I don't think it will happen. Another thing is that I believe the physiotherapy is more effective in case of back pain, not neurogenic claudication. And in neurogenic claudication, there are some studies saying that epidural injections may be helpful, but not conventional physical therapy actions.
Okay, thank you, Professor.
I think we can finish here. What do you think? Aderehime and Yahya, you can tell your last words.
Thank you all of the speakers and to all of the audience. It was a very useful knowledge webinar, and we will again meet new webinar the next month. And I want to give the last speech to Professor Haidara.
Okay. Okay, thank you to all the participants. It is a very important topic, the spinal stenosis canal issue. We meet in every day in our practice, and thank you for this great point of view from all the speakers. Thank you to